I think that the guest joined, Dr. SAPTARSHI Chaudhary, today's. You can,
Yeah,
yeah,
rejoin,
okay.
sir.
He had joined,
Okay,
sir.
sir.
Saptarshi Chaudhary had already
You
joined.
can open your video also, sir. Now, today, good
Dr.
morning.
Saptarshi.
Good morning.
So I'm trying, but the thing is that my video is not getting on.
Okay, you try. Thank you all. And today is our 1204th day of our daily webinar. How long we were traveling this journey? We started this journey 1204th day before. It is continuously going on. It's a miracle that we never expected such a long run. Today, Dr. SAPTARSHI Chaudhary, MD, Homeopathy, is our guest. He's going to talk about ECG. Before starting our session, let us have an 1 minute silence prayer to get wisdom and knowledge from Dr. Saptarshi, and all we are waiting. And let us have an 1 minute
Meanwhile, I
silent
request
prayer.
Dr. Saptarshi. Meanwhile, I request Dr. Saptarshi, kindly,
Yes,
kindly open your video. Kindly open your video. Dr. Saptarshi, you are available now? Yeah.
yes, sir.
We can see you.
Yeah, I think.
Yeah. Good morning.
Yes.
Good evening,
Yeah.
Dr. Saptarshi. Nice to see you.
Very good evening.
Good evening.
Very good evening.
Because so many
now you
people are,
continue, Dr. Kumar.
thank you, sir. So many people are waiting from different parts of the world. He is now, I think that Dr. Saptarshi is the first day he is coming for this platform. You should understand that from the different parts of the world, so many people are watching you. So this is a good platform for any doctor doing. Let us going through his, what is he? Let me say, Professor and Head Department of Practice of Medicine and Visiting Physician of Mahesh Bhattacharya Homeopathic Medical College and Hospital, Howrah. As professor since 31st and 5th, 2021, present Department of Practice of Medicine, Mahesh Bhattacharya Homeopathic Medical College, Hospital, Howrah, West Bengal. At present, Bhattacharya Medical College and Hospital, Howrah. 20 years of clinical experience. Experience as an examiner from 2011 and acted Head Department of Practice of Medicine, D&D Homeopathic Medical College, Hospital, West Bengal, Kolkata, acting as Head of Department Practice of Medicine, Mahesh Bhattacharya Homeopathic Medical College, Hospital, and as a Secretary, Board of Studies, undergraduate, the West Bengal University of Health Sciences for the Practice of Medicine subject from 2022 onwards. Acting as a member, Scientific Review Committee and Ethical Committee, Dr. D.E.D. Homeopathic Medical College, Hospital. Education, MD Homeopathy in Practice of Medicine from JRN Rajasthan Vidyapith, University of Udaipur, Rajasthan, BHMS University of Calcutta, and today is dealing subject, basic interpretation of ECG, required for homeopathic physician in daily practice. We know that heart is the first muscle cells are forming in our body. The first pulsation starts from heart. So it will beat from the beginning of our life till our end. So it is, we know that what is ECG? When we are, while we are studying in the 80s, that time only ECG is the most important tool for understanding the heart muscles and heart diseases. After that, there are so many tests that came, and that time it was a doctor on who knows about ECG is the top person. So now there are so many tools are there, but today a doctor is going to talk. It will be, I think that there will be 2-3 parts He told that 2-3 parts will be there. So you must, all of you must hear each and everything, whatever doctor says, and this is a good opportunity for us. Doctor, you are welcome. Now for the 45 minutes, your talk, and there will be a 15 minutes discussions part will be. So you are most welcome to our platform, sir. You can start now.
Thank you very much, sir. The thing is that since it's a very big topic, so I'd like to, deliver my whatever my content over here in 2-3 parts, if possible. And one more thing is that, first of all, my sincere thanks goes to Mridul Shahani, sir, and all the organizers of this particular platform. And another thing I'd like to say, if you allow me, then I'll continue the whole session, and I'd love to take whatever questions you have through my email, and I'll be happy to reply through the email, because 45-minute session, I think it will be very crunchy. I mean, it will not be very time. Now, the thing is that why I have chosen this particular topic, since there are so many other kind of devices by which we can diagnose the cardiac disease right now. The thing is that ECG is a very basic tool, and it's very much available in any setting. And even if a doctor is practicing in a faraway place
sorry,
where
doctor,
from where he can.
Sorry, Dr. Saptari. Dr. Saptari,
Yes,
don't be faster. If you cannot finish in one session, we'll give you another session also. So you can take the 2 or 3
Actually, I have divided
any number of
3.
the.
Okay, fine, sir. Thank you, sir. Thank you very much.
So
Now,
we'll fix up the date for the second part, third part, whatever you may say.
Okay, sir. Thank you very much. Okay.
So that we can have a better.
Okay, I'd like to take your permission. I'll just stop my video. I'll share my screen.
Yeah, you can share, sir. You are host now.
Yes, I'm sharing my screen if possible. Yeah, desktop. Now, the thing is that, okay. Can you see my screen?
Not yet.
Can you see my screen now?
No, sir.
Not yet.
Okay.
Please.
I think now.
Now it is
Yeah. Now it is
getting up.
okay.
Yeah.
Okay, fine. That's great. Now you can see, I think.
Okay.
Yes, sir?
Okay, doctor.
That's great. So, first of all, I would like to say a small prayer that we say, the Om Sarve Bhavantu Sukhina, Sarve Santu Niramayaha, Sarve Vadrani Pashyantu Ma, Kaschidukho Bhag Vavet. Om Shanti Shanti Shanti. Thing is that what I was saying, that first of all, we must remember one thing, that gadgets are there to, help us in diagnosis. Again, gadgets are not the entire thing. That's why we say the laboratory investigations are just another tool which help us in final diagnosis. And it can never ever replace a clinician with a proper clinical case record. And that is why we say a well-taken case is half cured. Now, I'll skip this thing. And what I have tried in my today's lecture is, there are so many, there are so many informations one can gather regarding ECG. But what I have tried here is to minimize the informations as much as possible, but without compromising the quality. So that's why I'll just, I know everybody knows this thing, but still I'll just try to brush up our memories, that we know whatever ECG we do in our clinical practice, this is basically a 12 lead ECG. And in this 12 lead, these leads are basically divided into 2 categories. One is 6 limb leads are there, and 6 chest leads are there. So of these 6 limb leads, 3 are basically the bipolar leads, or those we call the standard limb lead. That is basically a lead 1, lead 2, and lead 3. And there are 3 unipolar or augmented limb lead, we say, that is AVR, AVL, AVN. And there are 6 chest leads, of which V1 to V6. And V1, V2, we say it is a right ventricular chest lead. And V5, V6 are basically left ventricular chest lead. And V3, V4, we say these are the septal leads. Now, if we look at a ECG paper, then we can see these kind of graphs, and these graphs are basically we say PQRST, and sometimes U waves are also there, but basically this PQRS and T waves we can see. Now, in a graph, as we know from our maths knowledge, that it has got two basic axes. One is x-axis, which is horizontal, and one is y-axis, which is vertical. So along the x-axis, we measure time in ECG, and along the y-axis, we measure the voltage. Now, in every ECG machine in the world, there's some standardization. The standardization is such that in a second, this ECG paper travels on an ECG machine at a rate, and that particular rate is 25 small square per second. And this small square are basically 1 millimeter square, and that means in 1 second, 25 millimeter actually this ECG paper is moving. Since we are calculating the heart rate in a minute, so that's why 25 into 60 is 1500 small square is travel per minute. And this 1500 actually helps us to count us the heart rate from ECG. So that's why the heart rate is, we say, 1500 divided by R to R. That means from 1 R wave to another R wave. And along the y-axis, as we know, we count the voltage, and the voltage is it is again standardized that 1 millivolt, if passed through the stylus of ECG machine, it actually deflects 10 millimeter along the y-axis. So that's why that means 1 small square is equal to 0.1 millivolt. So these are very basic thing. And similarly, from the x-axis, we can find the time. That is 25 millimeter in 1 second. That means 1 millimeter is 1 upon 25 is equal to 0.04 second. But I'd rather ask every homeopath or my fellow homeopaths that we should rather consider the millimeter or the small square rather than going into this voltage or second, because easily we can multiply with the millivolt, and easily we can find out this second if we multiply the small room with 0.04 second, or if we multiply along the y-axis with 0.1 millivolt, we can count the voltage and second very easily. Now, in an ECG, so these are the basic findings. First is P wave, then PR interval. We all know this thing, and I think I should not waste much time over here. So this is just an ECG. We all know that thing. I'm skipping that slide. Now I'm coming here. The method of reading of ECG is, first of all, we have to see whether the P wave is there in every lead, as I have already discussed about the lead, and whether the P wave is always followed with a QRS complex. Similarly, the PQRST complexes in a particular lead we have to see, and usually we get 3 PQRST like this thing in each particular lead. Now, whether there is equal interval between the successive PQRST complexes and the detailed pattern of P wave, PR interval, QRS complexes, ST segment, T wave, U wave if present, and the QT interval, and study of the electrical axis of the heart. These are all very basic things. Now, coming to this particular P wave, while we are looking at the P wave in an ECG graph, we must remember chess. You know, we play chess, and there is one thing is that there is knight. So knight is actually moves 2.5 rooms, you know, in a chess. So like a knight, this P wave actually normally it can go along the y-axis 2.5 millimeter and along the x-axis 2.5 millimeter. So if we just remember that thing, it will be very easier for us to remember the main the normal P wave. Now P wave, what does it P wave actually indicate? Now this P wave is a first positive deflection. Positive deflection means the isoelectric line on which our stylus moves, and any deflection above the or towards above the isoelectric line, we say it's a positive deflection, or any deflection which is below the isoelectric line, we say a negative deflection. So in that way, the P wave is the first positive deflection in an ECG graph, and it is usually smooth and rounded, but sometimes that may be slightly notched. Now it indicates basically that our SA node is functioning, and because of the functioning of the SA node, there is atrial depolarization is there, or there is atrial contraction. So depolarization means contraction, and depolarization means relaxation. Now this P wave is better seen in leads 1, lead 2, in AVF and V1. In these leads, if we look at P wave, we can see the P wave properly. And normally it doesn't move more than 2.5 millimeter, both in X and Y axis, as I have already told you. And it is upright. This P wave remains upright in lead 1, lead 2, AVF, V4, V5, and V6. And it remain inverted normally in AVR as the electrical vector is coming from the other direction. So that's why the P is normally negative or inverted in AVR. And so obviously, if we know where it remains upright, then we should know, and where it remains inverted, easily we can find out the variables in other leads. So we must remember that P wave remains upright in lead 1, lead 2, AVF, V4, V5, V6, and it remains inverted in AVR. Now, this P wave, there are some common abnormalities of the P wave. Now, the P wave, there are some abnormalities which we usually see in our daily clinical practice. If we remember these small abnormalities, we can easily find out some disease condition. First of all, there are the abnormalities are P mitral, P pulmonal, and it's very common, and absent P wave, inverted P wave, and sometimes P wave is replaced with a sawtooth pattern of P wave that we say, and there are some F wave we say. Now, sawtooth pattern is found in case of atrial flutter, and F wave is generally found in case of atrial fibrillation. Now, if we here we can see this P wave moves, as we have already said, along the x-axis 2.5 millimeter. Okay. Now, if the notch is formed in the P wave, where is actually P wave is moving more than 2.5 millimeter along the x-axis, it may form a notch, but provided, mind it, this particular notch has to at least go 1 millimeter or 1 millimeter. That means it has to travel at least where this notch has to travel. The two peak, the gap between the two peak of P wave should be 1 millimeter. Otherwise, we cannot say it's a P mitral. Now, this P mitral pattern is found in case of left atrial enlargement. We have a habit of saying this P mitral, that means mitral stenosis. No, not only mitral stenosis, any cause, any disease condition which may initiate or which may cause left atrial enlargement will form this kind of P mitral. So this is very common. Now, coming into this was along the x-axis. Now, if we come along the y-axis, this P wave, if sometimes moves along the y-axis more than 2.5 millimeter, then this P wave is called tall and peaked P wave. And this kind of tall and peaked P wave is found in case of right atrial enlargement. So P mitral was in case of left atrial enlargement, and P pulmonal is very easy to remember in case of right atrial enlargement. So right atrial enlargement, there were so many causes, but very common causes what we find in case of pulmonary artery hypertension, in case of in case of cor pulmonale, in case of if there is ventricular septal defect, so in case of atrial septal defect, so in case if there is any kind of tricuspid stenosis, tricuspid regurgitation, pulmonary regurgitation, so there are so many causes which may cause this kind of right atrial enlargement. So in any case of right atrial enlargement, there will be this kind of P pulmonale. So having said that, sometimes in a ECG, we find that there may be absent P wave. P wave is absent, and which is very commonly we find in case of if there is formation of any kind of extrasystole. In case of extrasystole, like in case of atrial fibrillation, if there is any nodal rhythm formation, or if there is some very commonly in case of ectopic beat formation. So if so happens, it sometimes actually bar the normal P wave, and or if there is any kind of retrograde propagation of, excuse me. Am I audible? Hello.
Not audible, sir. Muted.
Right. Okay.
Somebody.
Okay. So if there is any ectopic beat with retrograde propagation, they may bar the normal P wave, and in that case, the P wave will remain absent. So while we get a ECG where P wave is absent, that means either the AC node is not properly functioning. It may be there is sometimes if there is an sick sinus syndrome, or if there is a AC block or AC arrest, it may be. But we commonly find this kind of thing in case of formation of ectopic beats, or where there is any chance of formation of extrasystole because of ectopic beat, or atrial fibrillation, as I have already told you, it is generally replaced, or if there is any nodal rhythm. Now, coming to inverted P wave, inverted P wave again found in case of if there is any kind of ventricular ectopics with retrograde propagation of the impulse. It actually there we find sometimes the P wave inverted, and there is if there is nodal beats and if there is nodal tachycardia, then also we can find this kind of P wave is inverted. But P wave normally we have to remember this thing. P wave remain inverted normally in AVR, and sometimes even in case of dextrocardia, in case of lipocardia, P wave may be inverted. Now this, as I was saying, the normal P wave sometimes is replaced with this kind of sawtooth appearance. Now, if we look at the ECG here, there we can see there is a sawtooth appearance or a garden brick appearance type of P wave, and which is fine in case of atrial flutter. But here we have to remember, if there is this kind of if on the left side you can see here in the lead 3 and AVF, here the P wave is basically anti-clockwise, and on the right side, if you see it's a clockwise. We don't have to go into detail of this thing, but what we have to find out here in case of atrial flutter, there is a relationship between this P wave and a QRS complex. We can see there may be 2 P wave followed by 1 QRS complex, or 3 P wave followed by 1 QRS complex, like 2:1 or 3:1 or 4:1. So there is a specific relationship. And what happens here is that all the waves which or all the electrical impulses which has been formed in the atria, they are not propagated into the ventricle, okay, because of the it cannot pass through the AV node, and that's why there is 2 or 3 or 4 atrial impulses and followed by 1 ventricular impulse, QRS complex. Okay, so this kind of thing, actually there is a relationship in case of atrial flutter. Sorry. Now, in another condition where we cannot find this any kind of normal P wave or nor a garden brick appearance or a sawtooth appearance, the P wave is just a wizard, and there is no relationship between the P wave, and there's no, obviously there's no normal morphology of P wave, and there is no relationship of this P wave or whatever the wave we have found generating because from the atria, it has no relationship with the QRS complex. And this kind of wave, we say it's a fibrillatory wave or F wave, and this kind of wave are best seen basically in lead V1 or V1 chest lead. Okay, so this is found in case of in case of atrial fibrillation. So this we say, that's why we say it's a fibrillatory wave. Now these were the P wave abnormalities. Now, if we can remember this very small thing in P wave abnormality, we can find out so many disease condition. Now, next, coming to PR interval. So PR interval, that means from the beginning of the P wave up to the beginning of the QRS complex, it's a PR interval, and that indicates the conduction time from of the impulse from which is traveling from the AC node to the ventricle through the AV node. A normal PR interval, as we have already told, that P wave is 2.5 millimeter maximum, or a night of a chase. Now from the 2.5 to 5.5, that is the range of this normal range of this PR interval, 2.5 small square to 5.5 small square. If I want to find it in second, we can just multiply 2.5 or 5.5 into 0.04 second. Easily we can find out that thing. So the normal PR interval is 2.5 small square to 5.5 small square. And it should be studied. This PR interval should be studied in every lead, and it should be counted on the x-axis. Now abnormalities of the PR interval, the common abnormalities of the PR interval is that the PR interval may be prolonged. Okay, now when we say its PR interval is prolonged, if the PR interval is more than 5.5 small square on the x-axis, and it actually indicates that the propagation time of electrical impulse from atria to ventricle is actually from AC node to AV node, and then activation of the ventricle is actually increased. So that indicates basically heart block, and we very commonly find in case of rheumatic carditis. As we know, in our country, this rheumatic carditis still nowadays even it is present. And that is why when a patient is coming to us, or when a child is coming to us, and obviously their parents are or the child is complaining of, or preschool going or school going child, they are complaining of he or she is having repeated upper respiratory tract infection, we become very alert, and we routinely go for this ASO titer, and go for, if I find the ASO titer is positive, and if I find any kind of problem, then we routinely go for this kind of ECG. So if a child is coming to you, if a child is coming to us basically with if there is a history of repeated upper respiratory tract infection or repeated respiratory tract infection, my earnest request to all my fellow colleagues and or whoever is listening to me is that be very alert, and please find out whether the patient is suffering from any kind of repeated sore throat, that means because of Streptococcus beta hemolyticus infection, or if the child is suffering from atopic allergic condition, or mind it, please, that if there is any kind of congenital heart disease, the repeated respiratory tract infection is a very common thing in a child. And I have seen cases. I have seen one lady. She actually came to our OPD a few days back, and she was having a syncopal attack. And what we found that the patient, the lady was having, biventricular failure, because she actually had ventricular septal defect from a very childhood. She was treated by the local homeopath doctor, a local doctor, while she was a child, and she was having repeated respiratory tract infection, and nobody actually bothered to examine her. And now her days are basically numbered. Now she has developed a severe pulmonary artery hypertension, and there is biventricular failure. She is in a mess. Now her days are numbered. So if the doctor who was examining the child when she was a child, if who was examining her, if he or she would have been a bit alert, and just a small examination, a small stethoscope examination, a small auscultation of the heart would have saved her life. Now, so that's why I'm asking you. Now, peer interval shortened, that means peer interval, if the peer interval is less than 2.5 small square along the x-axis, that indicates there may be atrial ectopic beat, and there may be sometime nodal ectopic beat, and there is a WPW syndrome. In this particular ECG, what we are seeing on the bottom, it's basically a WPW syndrome where the peer interval have been shortened and the QRS complex is broadened, and there is a delta wave formation. So if time permits, we will come to WPW syndrome later. We can have a detailed discussion where there is a re-entry phenomenon. Now, abnormalities of the peer interval. This is a very common thing which we find in our ECG. Now, this first of all, the first one, this first degree AV block. Why this is a first degree AV block? There is a peer interval is increased. We can see from the ECG, but each P wave is followed by a QRS complex. See, there is no drop of QRS complex in any way. That means the atria from the atria have contracted, and the ventricle has also reciprocated following the atrial contraction, and there is no beat has escaped, or no beat has barred to cross the AV node. So that's why there is no drop of QRS complex. So P wave is there and QRS complex is there, but the PR interval has increased. That is the first degree heart block. Now, coming to the second degree heart block, it has got two major types. One is Mobitz type 1 and one is Mobitz type 2. In Mobitz type 1, we can see the PR interval is gradually progressing, and while gradually progressing, after one P wave, there is no QRS complex. That means there is a drop of QRS complex. So this is called Mobitz type 1 second degree heart block. And in case of Mobitz type 2 second degree heart block, there is peer interval is we can see here the peer interval P is followed by QRS complex, but this this time lag is more, but this is fixed, and it is not, there is no gradual progression of this peer interval, but there is a sudden drop of QRS complex. So clinically, we say the second degree heart block or second degree Mobitz type 2 block is much more important than Mobitz type 1. And there is a second degree heart block of 2:1 block is also there, where we can see that P is followed by a QRS complex, and again there is a drop of this thing. So 2P is there followed by a QRS complex, and then again 1P and second P, and there is a drop of a QRS complex. So there is a 2:1 block. So these are the types of heart block. Third degree heart block I'll discuss later. So there's a first degree heart block and second degree heart block. Second degree heart block has got three different varieties. We can see one is Mobitz type 1, one is Mobitz type 2, and there's a second degree AV block. Now, the Q wave. Now, regarding this Q wave, we have to be very cautious regarding this Q wave. We have to find out the Q wave, whether the Q wave is there. Now it indicates actually depolarization of the interventricular septum and there is a bioelectricity passing from the left side and actually from the right. That means activation of the left ventricle first and then the right ventricle. So that indicates that the depolarization of the interventricular septum. Now it's measured from the end of the P wave to the beginning of the R wave, and the normal duration is not more than 1 millimeter in the x-axis. That means not more than 0.04 second, and it is the depth of the y-axis is not more than 2 millimeter along the y-axis. Okay, so that we have to remember usually. Now this is a very basic information, but if we can remember this basic information, we can easily find out some few important things. Now usually it's depth in the y-axis, as we have said, that if it is more than 2 millimeter or more than 25% of the QRS complex, that indicates a myocardial infarction or myocardial necrosis. But remember, in COPD, sometimes mimicking of such Q wave is also found. So usually, if again, that's why in the very beginning, I told you that history of the case or the symptomatology of the case with which a case is coming to us is very, very important, because we have to match our clinical findings. We have to match the history, the clinical finding, and the ECG finding or the lab finding, what we are getting, to come to a conclusive diagnosis. So if there is a deep Q wave, that actually gives us a hunch there may be a case of myocardial infarction. It may be acute myocardial infarction, or it may be a old MI. It can also depict. So I'll come to that. Now, in case of COPD, this may also be mimicked. Now, one small thing that is known as ventricular activation prime, or that is also called intrinsic or deflection. And this we have to see in chest lead V1, V5, or V6. And this is nothing but if we from the Q wave on the, or rather we can say on the Q wave, if we draw a perpendicular line, and if we measure the distance from the perpendicular line to the R wave, and this duration is known as ventricular activation time. Normally in V1, it is up to 0.02 second or half small square. And obviously the measurement is on the x-axis. Okay, you just look at this particular ECG graph. There's a perpendicular line on the Q wave, and from the perpendicular line, you just see the measurement of the tip of the R wave, or the R wave rather, not the tip of the R wave. And if this particular distance in case of V1, it normally is 0.02 second, and in case of V5, V6, it is normally 0.04 second. And it actually indicates the duration of electrical impulses to reach the ventricular surface from the left side of the interventricular septum. Now, if there is any increase of this ventricular activation time, or VAT, or intrinsic or deflection, that actually indicates, if it is more than 0.02 second in V1, it actually gives us an indication that there may be a chance of right ventricular hypertrophy. And if it is more than 0.04 second in V5 and V6, that actually gives us a hunch of left ventricular hypertrophy, or if there is any kind of ventricular dilatation or any kind of conduction defect. So that is why in that way ventricular activation time is important to us. Now, one more important thing is, after that ventricular activation time is the ST segment, and this ST segment end of the S wave to the beginning of the T wave. Normally it's isoelectric, and it actually indicates time taken between the ventricular depolarization to the ventricular repolarization. As we know, this QRS complex is actually indicates the ventricular depolarization or ventricular contraction, and T wave indicates actually ventricular repolarization or ventricular relaxation. Mind that the P wave is actually indicates the atrial contraction or atrial depolarization, but the atrial depolarization we do not get in ECG because it's barred within this QRS complex. Now this in the limb lead, this ST segment may elevate 1 millimeter, and that is normal. And in the chest lead, this ST segment may elevate in the y-axis, obviously 2 millimeter. That is quite normal. But in any case, be it a chest lead or be it limb lead, this ST segment is not allowed to depress below half small square. Okay, in the x-axis, if it is less, if the ST segment is depressed more than half millimeter or half small square, then we consider it may be a case of ST depression. Now, abnormalities of the ST segment is ST segment elevation or ST segment depression. Now, ST segment elevation in the limb lead, as we have already told, that if it is more, in the limb lead, it should not go beyond 1 millimeter elevation. So in the limb lead, if it goes beyond 1 millimeter elevation, and in the chest lead, if it goes beyond 2 millimeter of elevation, that indicates in case of acute myocardial infarction. It's very common. Now, regarding this acute myocardial, that we say the ST elevated myocardial infarction, and we have to be very, very careful regarding this ST segment, because easily we can find out a patient with ST, this myocardial infarction, because we know that myocardial infarction, the typical myocardial infarction symptomatology we read, that this kind of the symptomatology may be like a cactus grandiflorus. No, this kind of pain hardly comes. Most of the time patient comes with a sensation as if I'm having some gas, doctor, as if I'm having some sort of indigestion. Very rarely patient says as if I'm having a heavy stone has been placed on my chest. Sometimes patients say as if I'm having heartburn like a feeling, or mostly the patients say as if I'm suffering from gas. So that is why if a patient has a history of any kind of hypertension, or if there's a history of any kind of metabolic syndrome, or if the patient is having antihypertensive drugs, or the patient is having dyslipidemia, and obviously and these kind of people are saying this, I'm having such kind of thing, please do not ignore the thing saying that you are having some sort of gas, because most of the time the symptomatology of acute myocardial infarction comes with the features of sometimes we say it's just acid peptic disorder, you are having some sort of gastritis. No, I have seen patient who have died only because of that thing. He actually went to a doctor who diagnosed, no, you actually have some abdomen peptic ulcer syndrome, or you are having some acute gastritis, that's why you just take this antacids and you will be okay. And what happened, he went to the doctor at the evening, and the next day when he was taken to hospital, he was brought dead. And that was a massive myocardial infarction. And obviously sometimes we have to be very alert, because in case of diabetic patient there may be no pain. So in any case, if any patient comes to us with this kind of, if there is that kind of history, and if there is any kind of this thing, if we get ECG with there is ST elevation, we have to be very, very careful that it may be a case of acute myocardial infarction, or it may be pericarditis, and in case of ventricular aneurysm also. Now, having said that, if there is ST depression, now this ST depression, as I have already told, that even in case of a chest lead or be it a limb lead, it should not be depressed more than half small square. And so if the ST segment is depressed, and even sometimes we say if the ST segment is going parallel with the isoelectric line more than 2 millimeter, then again we sometimes consider it as an ST segment depression. Now, this ST segment depression is found in case of myocardial ischemia, in case of non-STEMI, in case of subendocardial myocardial infarction, in case of digitalis effect, we hardly get nowadays. Now, ventricular strain pattern, and also in case of hypokalemia. So, ST depression, we have to again think of myocardial ischemia, but remember, there are some situations where there is non-ST elevated myocardial infarction. So, if there is any kind of problem with the ST segment, we have to be very, very alert, and we have to go for a troponin T or troponin I or CPKMB test. Okay, so troponin I is very sensitive, but it's costly. But troponin T we can do, and obviously it will readily give us information regarding whether the patient is suffering from myocardial infarction, and we can at least give obviously if chance is given, we can discuss some drug which has a very good effect, or at least we can refer the patient, because first 1 hour we know the golden hour, where if we can diagnose the patient and we can send the patient to a proper care, patient can, the life, a very, very precious life can be saved. Now, this T wave following this ST segment, we can find this T wave. Again, T wave that indicates ventricular repolarization, as I have already told you. Now, upright, this T wave usually remains upright in lead 1, lead 2 AVF, and V3 to V6. And there's an inverted, and this normally, obviously, it is inverted in AVR. Inequally QRS complex is also inverted in R is inverted in case of AVR, and variable leads in lead 3 AVL, V1 and V2. Now, it indicates the ventricular repolarization or ventricular relaxation. Now, having said that, there are some abnormalities of the T wave for which we have to be very, very alert. If there is any kind of inverted T wave, and if there is a symmetrical inversion, okay, if there is a symmetrically inverted T wave where the both limbs of the T wave are similar in slope and length, and that indicates it's a myocardial infarction. Okay, now if the T wave is inverted but the both limbs are not in that way, we can also find that kind of T inversion in case of LVAH with strain pattern, where there is a ventricular strain pattern, we say. And now this coronary insufficiency, in case of digital effect, we can get this kind of T wave inversion. Now upright and pointed T wave or tall T wave we can find in case of hyperkalemia, in case of ST elevated MI, and in case of Prince-Betal angina. Now Prince-Betal angina, there, as I was talking about this ST segment depression, is angina, etc. Now in case Prince-Betal angina is again, it's a variant angina. Nowadays we do not get this kind of Prince-Betal angina, but it's Prince-Betal angina, we must remember that thing. It is usually found in case of patient, those who are having the chest precordial pain or the anginal pain at rest during the time of rest. And there is a basically a vasospastic, we say it's a vasospastic angina. It is usually found in case of female, and obviously in the early hours of the day. And there is the thing is that there is a major coronary artery, either they are normal or they are diseased, but they, because of their vasospasm, there is a anginal type of pain. But the thing is that there we get ST segment elevation. Now, to see whether there is a myocardial necrosis, to see or to differentiate it with the true ST elevated MI, we have to go for this cardiac biomarkers. And we have to look for this, again, CPKMB, TROP-T, TROP-I, very, very commonly that we use. Now, with Prince-Betal angina, I will rather say some other conditions, what we call a syndrome X. Now, this syndrome X is also found in case of perimenopausal or postmenopausal women again. Now, thing is that there is also a vasospasm actually happens, but these vasospasms are actually, they happens in case of very micro vasculature, and that's why it is said as a microvascular angina. We say it's a microvascular angina because if you go for, if this kind of patient usually comes to us after visiting, the cardiologist, where the patient has already undergone this angiogram, and in angiogram they have not found anything else, and obviously that is why it is called, it is syndrome X, and this is there's a microvascular angina, and we have got a very good scope of treatment here. And obviously there is no pathological changes over there, and there is no occlusion is actually and there is another syndrome which we say is syndrome Y. The syndrome X is somewhat different with the syndrome Y. In syndrome X, we say it's a microvascular angina, but in case of syndrome Y, there is a coronary slow flow phenomena, we say. And here in angiographically, which can be said that there is a delay in the distal vessel opacification actually happens. And these patients also can be dealt with our medication. But obviously these nowadays the nitroglycerin and calcium channel blocker they used to give, but we have scope. And another term I would like to say over here, this syndrome Z. Syndrome Z is actually found in case of patient those who are suffering from metabolic syndrome, and if they are having, along with the metabolic syndrome, they are having obstructive sleep apnea. Now this snoring, this huge snoring, we usually don't care if a patient is coming to us and saying my husband snores very much, I cannot sleep with him. Or sometimes the people say, or that I used to snore, sir, is hugely, do you have any kind of medicine? First and foremost thing, as a doctor, we have to find out whether the patient is suffering from obstructive sleep apnea, because obstructive sleep apnea itself can cause death in a patient. Or obstructive sleep apnea is now obstructive sleep apnea, it may be a peripheral and central, you all know. But if this obstructive sleep apnea is actually coming with in a patient who is having hypertension, who is having central line obesity, who is having insulin resistance, and who is having dyslipidemia or hyperlipidemia, then that condition, this cluster of symptom, we say this is syndrome Z, and we have to be very, very careful while dealing with such patient. Okay, because these kind of patient may anytime develop coronary artery disease. or patient may die out of it. Now, biphasic T wave, sometimes that indicates the Whale syndrome or stenosis of the proximal left anterior descending coronary artery. And so biphasic T wave is another thing that we have to look for. You can see the biphasic T wave over here. Now, having, in this connection, I will just say how to find out the wall involvement. As I was saying, which wall is particularly left. Now, this is a very short, very precise, but very effective way of understanding which wall is actually involved. We say in ECG, the anterior wall is depicted by lead 1 with or without lead 2. The posterior inferior wall is depicted by lead 3, AVF, with or without lead 2. The septal wall is basically indicated with the lead V3 and V4. Lateral wall is basically indicated with the V5 and V6. So if we join that, anteroseptal wall, that means lead 1, V3, V4 with or without lead 2. Anterolateral wall, lead 1, V5, V6 with or without lead 2. Posterolateral wall, that means lead 2, lead 3, AVF and V6. There are some other ways of finding out this wall involvement in ECG. But I think as far as my understanding, this is perhaps the most easiest thing or the most easiest chart by which we can easily remember which wall has involved. Okay, now as I was talking about this myocardial infarction, now there are some changes in case of immediate myocardial infarction or recent onset myocardial infarction or MI of some duration. That is regarding regarding of ST elevated MI. Now, in case of myocardial infarction, now this myocardial infarction can be of acute infarction, it can be of subacute infarction, it can be of subendocardial variety of infarction, it may be subepicardial variety of infarction, it may be intramural infarction, it may be myocardial infarction with unusual ECG pattern, it may be old infarction, and it may be ventricular aneurysm. So in myocardial infarction, varieties of myocardial infarction or varieties of ECG we may find, these are the varieties. Now, if we come here in this ECG sequence of ECGs, a sequence of changes in the ECG in case of acute ST elevated MI. The first one is the normal thing, and the second one we can see the ST segment has been elevated, and the T wave is barred within the ST segment. This is just it's an acute condition. After a few hours, if we look at the patient's ECG, we can see the third one where the T wave has formed, but ST segment is again elevated over there. Now, after 48 or 72 hours, if we go for another ECG, see the recent 2 ECG, the T wave is now formed, and there is a Q wave. See the Q wave. The Q wave, now the Q wave has come down. The Q wave is deep Q wave is formed. Now there is a formation of deep Q wave. ST segment is elevated. T wave is inverted, and then again after some duration, if after for 5-6 days, if you go for ECG, then of some duration ECG where we can see the deep Q wave is present, and there's a T wave and a symmetrical, the symmetrical right and left arms of this T wave we can see over there, and see the old MI. The funny thing is that in old MI, we are getting the P is there, is okay, the R is okay, the ST segment is okay, and the T wave is okay, but this deep Q wave, that actually remains. And if such deep Q wave remains, if the patient comes to us with the ECG, and if the ECG shows that the presence of deep Q wave, apart from and every other thing is quite normal, we can easily find out that patient has a history of myocardial infarction, and we can cross-check that thing with the patient. So the deep Q wave is extremely important. Again, subacute infarction, as I told you, in subacute infarction is characterized by the ECG of recent or sometime onset MI from the very beginning. Now, I'm going back. This recent or sometime duration, if we look this recent to and the sometime duration variety, this kind of thing is found in case from the very beginning in case of subacute infarction. We can see the ECG over here, if you can see. Okay, now, so this is subacute infarction. Then coming to this subendocardial infarction, the subendocardial infarction is characterized by deep ST segment depression. This ST segment, so that means it's a ST non-ST elevated MI. So there is a ST segment depression is there, more than 3 millimeter, deep and pointed and usually symmetrical T wave, and there is no abnormal Q wave. Funny thing is that in case of subendocardial infarction, we generally do not get this kind of abnormal Q wave. So subendocardial infarction, it is found in case of non-ST elevated myocardial infarction where there is a deep ST segment depression, deep pointed and usually symmetrical T wave, but there is no Q wave formation. So this is another variety subendocardial. So this is a deviation from the normal or usual variety that we get. Now, another thing is that subepicardial variety. Now, this epicardial variety in this here in this variety, we see this is elevated ST segment, but there is no pathological Q wave. There was in the previous slide, there was ST segment depressed, but now here in subepicardial, there is elevated ST segment, but there is no pathological Q wave. Okay, so we are here. You can see the ST segment is clearly can be seen the inferior lead, as I have already told you. The inferior lead is lead 3 and AVF. We can see the lead 3 and AVF, and obviously lead 2 with or without lead 2. And this acute subepicardial injury, here we can see. So this particular here, we can easily see the ST segment is elevation is there, but deep Q wave formation is not there. So this is called subepicardial infarction. Now, another variety, that intramural myocardial infarction. Now, intramural myocardial infarction is characterized by there is a significant Q wave depression. We can see there's a significant deep Q wave, and there is no significant change of the ST segment or T wave. We can see there is no significant change of ST segment or T wave, but there's a significant Q wave, and this is found in the intramural MI. If there is an intramural MI, and obviously it is and this is from the very beginning. So just a patient comes to us with an acute cardiac pain or acute precordial pain, and if you go for ECG and if you find this kind of ECG changes, we can say that this particular patient is suffering from intramural myocardial infarction. Now, another variety is there. That's old MI, as I have already told you. And old MI is characterized by significantly abnormal Q wave, and this isoelectric ST segment and normal or biphasic or flattened or inverted T wave sometime. So this deep Q wave we can see here. So deep Q wave we can see it's very easily the posterior inferior valve. If you look at the posterior inferior valve, we can see the deep Q wave. If you look at the lead 2 and lead 3 in AVF, you can see the deep Q wave is there. So that is actually old MI. So again, from the history and the ECG will give us the hint of our diagnosis. Now, ventricular aneurysm, if ECG shows the features of acute myocardial infarction, that is prominent Q wave as I have an elevated ST segment, that is STE-MI and ST segment, and there is and even after a few months, and if this kind of changes, if that remains even after a few months of onset of if from the history, if we can get that this kind of patient had a history of myocardial infarction, but even after a few months there's a prominent, or even after a significant time there's a prominent Q wave and there is an elevated ST segment. So there's a so we can easily say that sorry, is a mic, this thing is not moving. Here we can see, yeah. Now the elevated ST segment and the T wave inversion is there even after a few months. So we can say there may be a ventricular aneurysm, but we have tools for that thing. We have a simple 2D echocardiography of can diagnose this thing. These things we nowadays we do not get. But why I have uttered this thing, because just to say these are some abnormal condition we may sometime find in our clinical practice or may not. But this ST segment elevated MI, non-ST segment elevated MI, and these things are very, very common, and we have to be very, very careful while diagnosing or while seeing this kind of ECG, because as I have already told you that first 1 hour is a golden period to save a patient life. And thing is that we have a habit of depending on the cardiologist for ECG interpretation. But my earnest request is that And then every homeopath doctor, we are doctor first, and we prescribe on the basis of symptom similarity, following the principles of homeopathy. That's why we are homeopathic doctor, but we are doctor first. We are physician first. So we have to at least know the basic investigation tools by which we can easily find out, and by which we can at least help a patient. We can select our medicine, we can give medicine, at least we can refer the patient. And before referring, mind it, we have good amount of drugs, we have very good homeopathic medicines by which we can save patient's life. At least we can send him to the proper care. Now, this corrected QT segment, I'll skip that thing, it's not required. Now, QRS complex is another feature, and this QRS complex should be studied in every lead, and both in bipolar and unipolar lead. And there is in bipolar and unipolar limb lead, the main deflection variable, actually a variable, except in AVR, where the main deflection is downward. Okay, there is a small R wave and there is a deep S wave. In chest lead, while moving from the right ventricular chest lead, that means from V1, V2 to left ventricular chest lead, that is V5, V6, the deep S wave changes to tall R wave. And this change actually happens in case of V3 and V4. So that's why V3 in V4 are known as transitional leads, though they give us information regarding the interventricular septum. Okay, and in V3 and V4, the normally the S and R usually remains almost equal. Now, this QRS complex should be measured from the beginning of the Q wave up to the end of the S wave in QRS complex. And in limb lead, the normal duration is maximum. In standard limb lead, is generally maximum up to 0.11 second, or we say it's a 0.12 second. That means 3 small square. In chest lead, it's maximum up to 0.12 second, because 0.11 or 0.12, it really doesn't matter. Now, if it is more, if this along the x-axis, if the if the QRS complex is wide, that indicates actually complete bundle branch block. I'll come to that later. It is very easy. Now, ventricular or supraventricular ectopics with aberrant conduction, WPW syndrome or ventricular excitation syndrome, and arborization block or ventricular aberration. So these are the things, but we have to remember for this wide QRS complex, at least for WPW syndrome, as I have already initially told, that there is a delta wave formation, and to detect complete bundle branch block. Okay, or if there is intraventricular conduction defect or arborization block. Okay, now see here the QRS complex. In V1, we can see this QRS complex. If we look at the QRS complex, see the first P wave we can see, then PR interval we can see, then the QRS complex is notched. Likewise, P wave, the QRS complex is notched, and notch is just like an M, and these two peaks of this R wave are known as R dash pattern. Okay, so this kind of QRS notched QRS complex, we say it's a R dash pattern. Okay, so this R dash pattern, if there, this actually indicates a bundle branch block. We know bundle of His, so bundle branch block. Now, if this V1, if this pardon me, if this kind of R dash pattern actually found in case of V1 and lead V1 and V2, we say it's a right bundle branch block. And if we get this R dash pattern in V5 and V6, we say it's a left bundle branch block. Now, if there is a bundle branch block is there, and along with that, if in standard limb lead 1, 2, or 3, if we find that the QRS complex is not wide, it's less than 0.11 second, or it's less than the width of QRS complex in standard limb lead is less than 3 small square, then we can easily say this particular bundle branch block is incomplete bundle branch block. And if this kind of R dash pattern is there, along with that, if in the limb lead we find the QRS complex is wide, how wide? More than 3 small square, we can easily say it's a complete bundle branch block. This is just this thing. So this kind of
Doctor, we have to start the next session. So we can make another section in the next coming time. We will arrange that time. So because we have to go for the next session. So I think that we can conclude here. From we had to make a block Okay, you are in block position, so let us block here from.
Okay, sir. Okay, sir. No issue. No issue. As I have initially told you that we really have a huge thing because I have so many. I think it's more than 120 or 30 slides, odd slides are there. And this is just because ECG. And after that, we can also go for, therapeutic and how will you how we used to deal patients with, the arrhythmias patient. Because we have, sir, scope. We have scope, and at least we can diagnose our cases, and at least if we even if we have a if you cannot treat the patient right away, we can at least save the patient by sending the patient to the nearest hospital where he can, his life can be saved. So life is we are treating patient, and a life is extremely important, irrespective of pathies. What is my pathy is not most important. The most important thing to me is my patient, and I have to save a patient. So that's why I have always emphasized that every of my student of BHMS student, those who are coming, or the PG student, they should know at least the basic of ECG, so that they can use it in their treatment with very much confidence in their treatment, and obviously they can save patient's life, and at least can refer the patient, because referral service is also a big service. Okay, so that is
Thank
my
you,
view.
sir.
Yeah.
Because very nice presentation and your classes are very nice, very useful for the practitioners. So now I think that now Dr. Danish will say he has to say something to you.
Yes, good evening, Dr. SAPTARSHI. It's
Very good
really,
evening, sir. Very good evening.
it's really a very good session from you, and really went through the importance and how one can study these ECG. Even a common man can understood how to study these things. That's the beauty of your presentation, and hope we can have some more presentation on about the same. And as we told earlier, we can fix it in January as per your convenience. And these are the things everyone should know what is what and how to differentiate one from the other. So this kind of homeopathic experts are doing great service to not only to homeopathy but also to the medical profession itself. So we are very happy, lucky to.
Dr. Kulyan Sharup sir is here. I obviously, sir, I hope I actually asked for your blessings, and I'm very happy to see you here, sir. I hope I have at least contributed something, and I at least, I mean, I think you are not disappointed with me. That's all I can say.
No. You really fulfilled all of our heart with your knowledge. I think Kalyan sir can say a few words. Please unmute, sir. Gayatri Singh, sir. Please unmute, sir. Please unmute.
Audible?
Yes.
SAPTARSHI, your lecture is very nice. I think you will come next meeting, and I am very happy to see you. Very long time. Thank you very much.
Thank you, sir.
So I am very happy to say the vote of thanks to Dr. SAPTARSHI.
SAPTARSHI.
Yes, sir, SAPTARSHI. It's on behalf of International Forum for Promoting Homeopathy, as well as on my behalf, we are thanking you once again, sir. Thank you.
Now we are concluding here. Thank you all, and Saptarshi sir, you must come for next sessions. Now we are passing to our Malayalam session. Dr. Danish, who is
Dr. Mariamma John will moderate the Malayalam session.
okay.
Please unmute. Please make co-host